do come a bit late, don't they? I'm not sure I'm stable on this. The truth is, vaginismus can be like your, griha pravesh. You build a nice house, you get so excited, and you invite all your guests, and then you go to open the lock. You have the key, but the lock doesn't open. I had a patient, a couple who came last week, and I'm just telling you that story to illustrate how many things can go wrong. And if it wasn't so serious, it might even be funny that it all happened in one couple. So this young couple, married for 5 years, in a relationship for over 9 years, and not able to have sex. She's terrified because on their wedding night, he grabbed her arms. He'd given a lot of alcohol before, based on the advice from his mother. He made her lie on her front, and when she was asleep, he forced himself on her, and she had a big tear, and she bled for 3 days, and since then she's not let him touch her. On top of that, his mother keeps telling him, you should divorce this woman, you should leave her. My God, young man, you need a life, you need to have great sex. What is this woman doing to you? So he keeps telling her, if you don't have sex with me, I'm going to leave you. If you don't have sex with me, I'm going to leave you. Then she goes to see a gynecologist who insists, put her arms down, be careful. She gets 2 house people to hold her down, tries to examine her. This poor woman is terrified. She doesn't go to a doctor. Next thing she goes, her husband and mother-in-law take her to another doctor, and they give her sedatives, says, put her to sleep. Guess what the woman does? She goes to the gallery and buries the tablets because she doesn't want to fall asleep. She stays awake all night because she doesn't want her husband to come near her. Now, can you find another case where there's more illustrations of what not to do in a case of vaginismus? So, Rosemary Basson actually told us this. This is persistent or recurrent difficulties of the woman to allow vaginal entry of the penis or a finger, any kind of object, even though she actually wants to do the act. She wants. So this is not rape, because she is actually interested in completing the act or interested in doing it, but she's not able to comply. The key aspect of vaginismus is the fear, the phobic avoidance of the process. At all times, it's not just a psychological problem, and we'll listen more about how it's not just a psychological problem, and we also need to rule out some of the structural issues that can happen in women with vaginismus. So DSM-4 also tells us about this issue. It describes genitopelvic pain disorders. So there's dyspareunia, there's anxiety and fear about the penetrative process, and there may or may not be associated marked tightening of the pelvic floor muscles during attempted penetration. This has a significant effect on the relationship, on the individual, and usually any kind of methods that they've attempted to overcome this haven't worked, and the problem has lasted more than 6 months. Then it becomes a proper dysfunction. Now, these categories, vaginal muscular spasms, pelvic floor muscle spasms, hypertonicity, tenderness, they can overlap with other conditions which cause dyspareunia, superficial dyspareunia, which is why it got included under genitopelvic pain disorders. So things like vulvodynia, things like vulvar dermatosis, other conditions which cause a lot of sensitivity in the area can also be associated with similar problems. So pain with sex is very common, or so it appears. But when you look at the Western literature, they don't quote it as more than between 5 and 17%. But when you start looking at Asian literature, Asian, Chinese, Middle Eastern literature, the incidence is reported anywhere between 25% to 68%. Certainly in my clinical practice, I see 7 out of every 10 patients is vaginismus. Unconsummated, vaginismus. They don't come as vaginismus, it will present as many other things, and we'll talk a little bit more about that. But the conclusion is that penetration is not allowed. One of the reasons for this kind of research discrepancy is because vaginismus, unconsummated marriage is a very kind of taboo subject. Women don't like to talk about their failures, neither do men. The fact that a couple are together and haven't consummated it is a big stigma in society. So women don't volunteer this information. Even in groups of women. Certainly, I have patients who say, oh, you know what? I heard those women talking about it. I didn't tell them we haven't had sex. We are feeling incomplete because we are part of a group of friends, we've all grown up together from school, but we can't talk about our sex life like everybody else can. We can't have kids. We can't tell them we've not had sex. So this problem affects couples in many different ways. And for this reason, when we're diagnosing vaginismus, we need to look at it as a multidimensional thing. The problem of non-consummation and vaginismus or pain and discomfort can show up as loss of desire, it can show as inability to get aroused, it can show as avoidance, and then it can also show up as desire disorders both in the man as well. And we'll talk a little bit more about that. It's true. How does male sexual dysfunction also present in the case of so-called vaginismus that comes to you? It's very important that we understand that there are certain scripts at the bottom. There's understandings, the meanings that the woman is giving her condition. What does it mean to have pleasure? What is it about power? Remember, power in a sexual relationship belongs to the person who can say no in the bedroom. Your ability to say no to a sexual encounter is what gives you power. So typically, a couple who comes and you have this kind of drama where the woman has no power whatsoever, where is the only place she gets to say no? That's how things get complicated, right? It's not as simple as not being able to penetrate. Which is why later on I'm going to tell you why it's not simply enough to dilate. So biopsychosocial model, we talk about this all the time. And certainly in biology, particularly female sexual dysfunction, you require intact systems. So all the neurology, the anatomy needs to be intact. Diseases like endometriosis, genital dermatosis, problems that cause a lot of pain and discomfort may be associated with dyspareunia and vaginismus, not superficial and deep. Things like happened as menopause, so secondary vaginismus, which we talk about, menopause, extreme vaginal dryness, genital urinary syndrome of menopause, associated bladder problems, even things like interstitial cystitis, it can be associated with pain. Herpetic, you just heard about sexually transmitted infections. Vulvodynia, secondary neuralgia resulting from herpes, chronic herpes infections is a very common problem why women do not want to entertain any kind of sexual encounter once it happens. Interpersonal problems. Having a relationship with a guy who doesn't rate you, is not willing to listen to you, is a no-go for many women. And then of course, it's psychology, depression, anxiety, the lack of engagement in a relationship, all of this can contribute. And then parental attitudes. Certainly in parental attitudes, it's the mother and daughter relationship which is key in vaginismus. And the programming that happens from childhood about what's going on with that particular relationship, with that sexual encounter, with what happens when you meet boys, come home before 7 o'clock, it's dangerous. All of these problems will contribute as predisposing factors, and this is something that we want to uncover when we do our history taking. Certainly, I've had many cases where there's a woman who had very, very traumatic childhood, very strict father, being beaten up for not performing, a lot of anxiety and stuff. She's got vaginismus, and of course, if you have experience of such patients, you'll often find that they choose husbands who are very gentle, very understanding. Please, I don't want to hurt her. And then you've got a mother or a father, they're dominating, who's trying to force her son into it. If only you could get it on, you should just force her, make her do it. And then the man gets blamed for not performing. So all of these are really entangled stuff in vaginismus. It's not as clear-cut as we think it is. So some medical conditions that are associated with vaginismus, we talked about that can contribute to the condition, which is important for you to rule out when you're assessing a case of vaginismus. So it's not just about pelvic floor muscle spasm, and it's not just about unconsummated marriage. All of these conditions can cause secondary vaginismus also. History taking, really important to take a good relationship history, like we talked about. Penetration history, what has she done before? Has she ever had any kind of fingering? Has she attempted to insert tampons, or even nowadays, girls are really keen on using menstrual cups. How long has it lasted for her? What are other influences? Who has she been speaking to about this problem? Any kind of social or cultural things that have affected her in her understanding? And then of course, the typical relationship where the man has erectile dysfunction or early ejaculation gets blamed for not being able to push it hard enough in. Relationship discord, exactly like the couple I described before. My question to you is, if you cannot talk to somebody, why would you want to have sex with them? If you cannot have a decent conversation where you can be vulnerable and open about your emotions, why would you let that person into you? There's a good reason why you don't want that person near you. So we need a team management approach. Even the same history-taking points, wherever this patient presents, whether it's to a gynecologist or a psychologist or a marital and relationship counselor, whether she presents even to a general medicine person because she's taking her husband along, she presents to the urologist because she's saying, my husband's got erectile dysfunction. All of this needs very sensitive handling, very careful history-taking. Her anxiety and trauma around penetration, around pregnancy and contraception. All of these things need to be addressed when we're educating her. The clinical examination process is critical, is very important as a clinician to be aware of how she's coming. How does she speak about her problem? So you've got to be able to listen, to watch how she's behaving when she's trying to get onto the couch. Is she really hesitating? Does she? How far does she want you to go? So reassuring her that she's in control, that she can tell you when to stop and that you will stop. That there's nobody there who's going to pin her down and force themselves into you. And constantly educating, maybe using a mirror to show her what you're looking at. How does the pelvic floor look? How does it tighten when she tightens? How does it relax when she relaxes? Can she use her own finger? Can she desensitize herself with you, guiding her and helping her? And then inquiring, what are the sensations, feelings, emotions coming up for her? It's very important to individualize the treatment and empower her to feel safe. And sensate focus becomes the foundation of this. Certainly I use sensate focus throughout, and I empower both partners equally. So I don't leave one person out. Like Dr. Gajanan Bhatt also talked about, Dr. Raj Brahma also talked about. Sexual problems are a couple issue. Dr. Ala Satyanarayana Reddy also talked about. The patient is not the problem. Your client is the marital relationship. So enhancing that relationship, improving communication becomes the foundation. And then when we come to Botox, again with the foundation of dilation, I'll talk about the ethics of this as well. There is not enough studies to show it's the only thing that works. It may work, but without the foundation of sensate focus, good communication, understanding and desensitization, it won't last very long. And there are too many patients today who continue to have pain and discomfort and tolerate penetration. They tolerate having sex. It's not because they're enjoying sex, it's not because they've owned the pleasure. So some predictors of successful outcomes is actually a really good relationship and openness to understanding about their genitals, where they're willing to listen to you, address their fears about penetration, and they're engaging with the therapy process, they're engaging with their homework, they do their homework sincerely. Those are where you get success. Failed ones, exactly the opposite. Obviously, they don't want to hear what you have to say. Their fear of penetration, their fear of engagement with the process is much greater than any solution you're willing to provide, and that's because we haven't addressed all of the biopsychosocial issues. That's because we haven't looked at what the in-laws are doing, we haven't looked at what the friends have told her, we haven't looked at the movies she explored first where a woman was raped and she screamed. So mostly, when patients don't engage with our therapy, it's because we haven't explored enough. Certain things which do not predict outcome of treatment, sexual abuse history, or if there are sexual dysfunctions in either of the partners. They don't predict. Once you manage that condition, even if you remember what Dr. Ram said, when you're walking down sensate focus, if you can't address it, you bypass it and move around it. Not every problem needs a solution, whether psychodynamically or psychotherapeutically. Sometimes you don't need to handle it then. She's not ready, but she can deal with the progress. It's very important to understand the ethical implications of the treatment of vaginismus. We have prioritized vaginal dilatation too far above sexual pleasure, intimacy, and long-term relationships. Yes, dilatation under anesthesia, cutting and doing perineuraphies under anesthesia, hymenoplasties under anesthesia. Forcible vaginal dilatation can give you penetration, can give you vaginal dilatation, but it does not give you pleasure, it does not give you engagement and a beautiful quality of life. So do use empathy, respect, educate your patient, be compassionate, offer solutions that she can implement, and be willing to walk side by side with her on this journey. For sure, don't dismiss her. Don't force a physical examination. Don't make any assumptions. Please, don't operate without any good reason. Thank you.
Thank you so much, Dr. Neelima, for driving home these points. I'm a fertility specialist and I see a lot of fertility issues coming up just because the woman has vaginismus. They want you to do an IUI under general anesthesia. And the other important mistake that gynecologists do is to take the woman aside and try to treat her when it is a couple's problem. And I think we need to see the couple together because the man needs to sensitize to the fear she is facing in the bedroom. And very often he is not aware of it. And I think another important point is that many patients present as vaginismus when actually the problem may be erectile dysfunction and they do not want, the male doesn't want to discuss it, or the erectile dysfunction is because of the vaginismus. Either way, they both potentiate each other and both have to be
exactly discussed. As you said, I didn't talk about the case because we ran out of time, but a couple who came to me a couple of months ago, they've been in a relationship for 10 years, married for 4 years. He has erectile dysfunction, labeled as erectile dysfunction, can't get it up, can't penetrate. And she's a doctor and she has never been examined. And then she turns up and I say, well, have you ever tried fingering? She says, oh, only the outside bit. What happens? Oh, I can't go any further, it hurts. Okay, and then what does she have? She has a septum.
Yes.
She has, partial septum. So she still bleeds, so she has menses,
Yes.
but there is a septum. And then he has phimosis. So no wonder, nobody's examined either him or her. So another pitfall is to keep doing psychotherapy.
And one important tip I wanted to leave the house with is that we often ask the woman to use her own finger because I think that is where she's in control. I ask her to do it in the shower, do it in the bedroom, and once she's comfortable with that sensation, only you can proceed with putting in dilators or any other device.
Thank you, ma'am. I request the chairperson to take the speaker. So as we finish